welcome back to the deep dive. So you've shared your revision notes on benign Rolandic epilepsy, or BRE.
Yep, got them right here.
Great. Our mission today, then, is to really break these down, pull out the absolute must-know info, and make sure it sticks for your revision.
Absolutely.
Yeah.
Make it clear, make it memorable, high-yield stuff.
Exactly. We'll cover, the definition, what causes it, risk factors, how it actually works in the brain,
What else it might look like, who gets it, the actual presentation.
how it's diagnosed, managed, the outlook,
Yeah.
and any potential issues. Basically, the full picture.
Sounds like a plan. Ready to jump in?
Let's do it. So, first things first, what is benign Rolandic epilepsy?
Okay, so BRE, or sometimes called benign epilepsy with centrotemporal spikes, it's a specific type of epilepsy found in children.
Childhood epilepsy, okay.
Yeah, and the really key things are seizures often happen at night, during sleep usually.
Right.
And the brilliant news, really, is that most kids grow out of it by the time they're teenagers.
Oh, that is good news.
Yeah. The onset is typically somewhere between, say, 4 and 12 years old. And that word benign is important. It highlights that it's generally not severe and tends to resolve.
Benign and resolving, got it. So what actually causes it? Why do some kids get this?
Well, that's the million-dollar question, isn't it? The honest answer is we don't know the exact cause for sure.
Okay.
But the evidence strongly points towards genetic factors being really important.
It's genetics. Okay.
Yeah, you often see a family history of epilepsy in these cases, and researchers are looking into specific gene variations that might be involved.
So it's less about something external happening, like an infection or injury. Your notes mention those for other types of childhood seizures.
Exactly. While things like, brain malformations, infections like meningitis, electrolyte problems, toxins, head trauma, metabolic disorders, they can cause seizures in kids, definitely.
Right.
But for BRE specifically, the thinking leans much more towards an underlying genetic predisposition. It seems to be more about the brain's inherent wiring, if you like.
Okay, so inherited tendency is the main suspect for BRE. That helps clarify things. Yeah. So then, who is most at risk? What are the key risk factors?
Well, building on what we just said, there are really two main things to keep in mind.
Okay.
First, that family history of epilepsy we mentioned. If epilepsy runs in the family, the chance is somewhat higher.
Makes sense.
And second, related to that are those underlying genetic factors. It really boils down to that genetic susceptibility.
So family and genes. Easy enough to remember.
Pretty much, yeah. Family and genes for BRE risks.
Right. Now let's get into the mechanism. What's happening inside the brain during a BRE seizure? What's the pathophysiology?
Okay, so the action is focused on a specific part of the brain, the centrotemporal region.
The centrotemporal.
Yeah. And this area is interesting because it's involved in controlling language and movement, particularly around the face, mouth, and tongue.
Ah, okay. Face and mouth control center.
Kind of, yeah.
Yeah.
And in BRE, there's this tendency for abnormal electrical discharges, like little electrical misfires, to happen right in that specific zone.
And because it's that area.
Exactly. Because of the location, those misfires translate directly into the symptoms we see in BRE seizures. Things like facial twitching, maybe some numbness or tingling, drooling, difficulty speaking.
So centrotemporal activity leads to those face and mouth symptoms. That clicks.
That's the connection. Centrotemporal equals face-mouth symptoms.
Okay, cool. Now, if a child comes in with symptoms like that, how do we know it's definitely BRE? What else could it be? The differential diagnosis.
Yes, the differential. Super important. You've got to consider other possibilities, right?
Definitely.
We can sort of group them into two camps. Other childhood epilepsy syndromes, and then conditions that aren't epilepsy at all, but might look similar.
Okay, let's start with other epilepsies.
Sure. So you might think about Paedopoulos syndrome, but that often has more vomiting and autonomic features, maybe longer seizures too.
Right, different flavor.
Then there's childhood absence epilepsy, but that's those classic staring spells. Very different from the focal facial stuff in BRE. Frontal lobe epilepsy can have motor features, yeah, but the pattern of the seizure and the EEG findings are usually quite distinct.
So the specifics focal phase, often at night, really point towards BRE.
They do. Plus, typically the child is developing normally otherwise, and the EEG between seizures looks okay apart from those specific spikes.
Okay, and what about the non-epilepsy mimics?
Right, the mimics. You've got things like syncope fainting, but that often has triggers like standing up too quickly or being in a crowded place.
Okay.
Night terrors, they can look traumatic with screaming and movement, but the key is the child usually has no memory of it afterwards. Amnesia is a big clue there.
Right, BRE kids usually remember, don't they? Or at least are aware during.
Often they retain some awareness, yes, especially if it happens while they're partially awake.
Yeah.
Then you have reflex anoxic seizures, usually in younger kids, triggered by a sudden shock or minor injury. Febrile convulsions, obviously linked to fever. Then, sadly, you have to keep in mind fabricated or induced illness, though that's rare.
A tough one.
It is. And don't forget cardiac causes, like arrhythmias, which can cause loss of consciousness. Migraines can sometimes have weird neurological symptoms. Even things like sleep apnea or narcolepsy need to be considered in the right context.
Wow, quite a list to rule out.
Yeah, but each usually has distinguishing features on careful history taking.
Okay, good to know. So how common is BRE? What's the epidemiology like?
Well, nailing down the exact prevalence in the UK is a bit tricky. The data isn't perfect.
Right.
But it's widely considered one of the most common epilepsy syndromes in childhood. It makes up a pretty hefty chunk of epilepsy diagnoses in that 4 to 12-year-old age group.
So relatively common then in pediatric terms.
Definitely. And just for context, epilepsy in general is more common in childhood than adulthood. Younger kids also have a bit of a higher risk for status epilepticus, those prolonged seizures. And while having a parent with epilepsy slightly increases the risk, it's still relatively low overall. But yeah, BRE is a major player in childhood epilepsy.
Good perspective. So let's picture it. What does a typical BRE seizure actually look like? The clinical presentation.
Okay, the classic BRE seizure is focal, starting in that centrotemporal spot we talked about.
Right, the face and mouth area.
Exactly. So the symptoms are mainly around the face, mouth, tongue. Think tingling, numbness, maybe twitching or jerking on one side of the face or mouth. Drooling is really common too.
Drooling, okay.
Speech can be affected. They might find it hard to talk or make sounds. And crucially, remember, they often happen during sleep or drowsiness.
Right, the nocturnal aspect again. Are they long seizures?
Usually not. Typically quite brief, maybe a minute or two, and they stop on their own. Self-limiting.
Okay, so focal face, frequent night.
That's a great way to remember it. Focal face, frequent night, perfect.
How does that compare to, say, other childhood seizures, like absent seizures?
Very different. Absence is that blank staring, loss of awareness, no facial twitching. Infantile spasms are those sudden, brief muscle contractions, usually in babies, often in clusters.
Okay.
Dravet syndrome is much more severe, multiple seizure types, hard to treat. Juvenile myoclonic epilepsy, that's more the morning limb jerks in teenagers.
Right.
Even Paediatrics syndrome, while also focal, often has that vomiting, maybe longer duration. And things like Lennox-Gastaut are complex syndromes with multiple seizure types and often developmental issues. BRE stands out with its specific facial features, the nocturnal tendency, and importantly,
The normal development between seizures.
exactly. That's a really key point. Between seizures, these kids are usually otherwise healthy and developing normally.
That's very reassuring. So how do doctors confirm it's BRE? What investigations are key?
Diagnosis really relies heavily on getting a good clinical picture. So a detailed history from the parents or caregivers is vital. Exactly what happens during the event, when it happens, any family history.
The story is crucial.
Absolutely. And a thorough physical and neurological exam. But the definitive test, the workhorse, is the EEG.
The brainwave test.
Yep, the electroencephalogram. In BRE, it typically shows a very characteristic pattern. Spikes or sharp waves coming from that centrotemporal region.
Ah, the spikes we mentioned earlier.
Exactly. Benign epilepsy with centrotemporal spikes, it's in the name. And importantly, these spikes often become much more obvious when the child is asleep.
So a sleep EEG might be particularly helpful.
Very often, yes. Sometimes if things aren't completely clear or to rule out any structural brain issue, an MRI scan might be done too.
Okay. And are there other general tests used when investigating seizures? Your notes mentioned a few.
Yeah, for seizures in general, depending on the situation, doctors might do an ECG to check the heart.
Right. Rule out cardiac causes.
Blood tests to look for metabolic things like low blood sugar or electrolyte imbalances. Neuroimaging like CT or MRI is important if a structural cause is suspected. And besides the routine EEG, sometimes a sleep-deprived EEG is done to try and provoke abnormalities, or an ambulatory EEG where the child wears the kit at home for 24 hours or more.
Right, to catch events. And when does a child need referring to a specialist after a seizure?
Good question. The guidelines are quite specific. Any child with a first suspected seizure should be seen by a specialist, usually a pediatrician with expertise in epilepsy, within 2 weeks.
2 weeks for a first seizure.
Yes. Also, if seizures come back after being controlled, that needs referral. And then for more complex cases, diagnosis uncertainty, difficult to control seizures, needing specialist assessment referral to a tertiary epilepsy service is needed, typically within 4 weeks.
And any urgent cases?
Yes, there are red flags for more urgent referral to a tertiary pediatric epilepsy center like kids under 3, certain seizure types like myoclonic seizures starting before age 4, or if there's a regression in their development.
Got it. So once BRE is diagnosed, how is it managed? What's the treatment plan usually?
Well, here's more good news. Given that most children naturally outgrow BRE,
Treatment might not always be needed.
exactly right. Often a watchful waiting approach is taken, especially if seizures are infrequent and not too disruptive.
Right.
However, if the seizures are frequent or if they're causing significant problems, maybe affecting sleep quality, causing anxiety or risk of injury, then antiepileptic medications or AEDs are considered.
So it's decided case by case.
Definitely. And regular follow-up appointments are key to monitor how things are going, decide if meds are needed, or adjust them if they've been started.
So not an automatic prescription pad situation.
Not at all for BRE. Generally, in childhood epilepsy, you'd consider medication if epilepsy is confirmed and ongoing. Sometimes even after a first seizure if the risk of recurrence is high. The aim is usually monotherapy, just one drug if possible.
Right.
But for BRE, because of that excellent prognosis, the threshold to start medication is often higher. Careful observation is frequently the first step.
And if medication is started, can it eventually be stopped?
Yes, that's a really important point. After a child has been seizure-free for at least 2 years, withdrawal of medication can definitely be considered based on an individual assessment with their doctor. There's a good chance they won't need it long-term.
Okay, that all sounds quite positive. So what is the overall long-term outlook, the prognosis?
The prognosis for typical BRE is honestly excellent. It's one of the most reassuring epilepsy diagnoses.
That's great to hear.
As we've said, the seizures almost always stop completely, usually by the late teens, sometimes even earlier. Epilepsy-related mortality is extremely rare, basically the same as the general population.
Fantastic.
Now, it's true, some other epilepsies can be challenging, maybe linked with learning difficulties.
But not typically BRE.
Not typically BRE, no. Continued seizures into adulthood are much more likely if there are other underlying neurological issues, very frequent or hard to control seizures early on, or other medical conditions. Your notes contrast BRE with tougher syndromes like Lennox-Gastaut, which really highlights how good the outlook for BRE usually is.
It's very reassuring. Okay, so given it's benign, are there any complications at all to be aware of?
Complications are rare, thankfully. The main potential issue, really, is the small risk of injury during a seizure.
Because they often happen at night.
Exactly. Falling out of bed, biting the tongue, those are possibilities. But simple precautions, like maybe bed guards for younger children, and just general awareness can really minimize these risks.
So manageable risks rather than serious long-term complications of the condition itself?
Precisely. It's more about managing the seizures safely while they're occurring.
Right. Okay, so to wrap this up and really cement it for revision, let's quickly hit the absolute key takeaways for benign Rolandic epilepsy.
Okay, the essentials. BRE, common childhood epilepsy. Focal seizures, often nocturnal. Think face, mouth, tongue symptoms. Likely genetic factors leading to abnormal electrical activity in the centrotemporal region. You see those characteristic spikes on the EEG, especially during sleep.
And the prognosis.
Excellent. Typically resolves by adolescence. The benign part is key. Usually no long-term impact on development or health.
So benign Rolandic resolving.
Perfect summary. Benign Rolandic resolving. If you remember that, you've got the core of it.
Brilliant. And listen, if you're revising for the MSRA and want more fantastic resources like this deep dive, definitely check out PassTheMSRA.com.
And don't forget freemsra.com for loads of free questions and guides, too.
Absolutely essential sites. Well, thank you so much for joining us for this deep dive into BRE.
My pleasure.
We really hope breaking it down like this has helped make it clearer and easier to remember for your revision. Keep up the great work, and we'll catch you on the next deep dive.